everyone. My name is Arunwan Prutipan. I'm the president of Asian Pediatric Pulmonology Society. I would like to welcome you all to our second APPS Grand Round. A 14-year-old Indian girl with enigmatic pleural effusion. I would like to express my sincere thanks to Indian Academy of Pediatrics National Respiratory Chapter to co-host this special educational activity. We are honored to have Professor Kalapanawa and the President and Professor Jadish Goyal, the Secretariat, to join our Zoom with us today. Before I send my microphone to Professor Valinder Singh, the moderator of our grand round today, I would like to thank all speakers who voluntarily conduct this activity for us. If you enjoy this kind of activity, we will have the next grand round hosted by Singaporean experts in March. So please join us. And now, please welcome Professor Valinder Singh. He is our APPS former president. He will be our moderator. Good luck, my dear friends.
Thank you, Professor Arunwan, and namaskar and greetings to everyone from India. Today, we're going to discuss a case which was quite enigmatic and had a lot of learning points. And I have with me a very august panel with Anna Nathan joining us from Malaysia. She is the Senior Consultant Pediatric Pulmonologist at University of Malaya, Kuala Lumpur. Welcome, Anna. And we have with us Professor Bulan Karada from University of Marmara, Faculty of Medicine, Istanbul, Turkey. Hi, Bulan, and welcome to the show. And we have with us Li Wei Gao. Professor Li Wei Gao is from the Beijing Children's Hospital, Capital Medical University, Beijing, China. I welcome you to the discussion, and I'm looking forward to all your contributions as we go forward. And the presenter for the case today is my colleague, Professor Kamal Kumar Singhal, who is a pediatric pulmonologist at Department of Pediatrics, Lady Hardinge Medical College, and Kalavati Sun Children's Hospital at New Delhi, Delhi. So over to Dr. Kamal Singhal to take you through this case, and let's get going. Over to you, Kamal.
Thank you, sir. Thank you so much. So we'll straight away start with the case. We have a 14-year-old girl, resident of New Delhi, and presented to us with complaints of cough for the past 2 weeks, difficulty in breathing for the past 1 week, and bilateral chest pain for the past 1 week. The child was apparently well 2 weeks back when she started having this cough, which was dry, subacute in onset, non-spasmodic, non-paroxysmal, with no diurnal variation, initially associated with coryza, without any post-recessive vomiting. For the past 1 week, the child had difficulty breathing, which was gradually progressive, and there was decreased exertional capacity of the child. But when the child presented to us, he had breathing difficulty at rest also. This was associated with chest pain for the past 1 week, which was bilateral diffuse, increased with cough, and not showing any change with change in position. This was not associated with any history of fever, weight loss, reduced appetite, or a contact with an open case of active tuberculosis. There was no history suggestive of atopy, rash, pyoderma, any abscesses, scabies, history suggestive of measles, skin rash, joint swellings, neck swellings, and there was no past history of severe multisystem infections requiring admission or any past history of recurrent respiratory distress or prolonged cough or nebulization. The family history, the birth detail history, development, immunization, and the dietary history was uneventful. The examination suggested tachycardia with a heart rate of 144 per minute with a respiratory rate of 44 per minute. The blood pressure, the pulse, the capillary refill time was normal. The child had suprasternal, intercostal, subcostal retractions along with nasal flare. The child was maintaining a saturation of 90% on room air and was 99% on nasal oxygen by mask. The anthropometry was normal, the weight, height, and the BMI. General physical examination was essentially normal with no pallor, icterus, cyanosis, no lymphadenopathy, ear, nose, throat examination normal. BCG scar was there, but there was no clubbing. JVP was not raised, no edema, hair, nails normal, and the skin did not have any boils, rash. The systemic examination, the respiratory system suggested pleural effusion bilaterally. The abdominal examination revealed liver 4 centimeters below costal margin, smooth surface, rounded margins. And the spleen was 1 centimeters below left costal margin. Rest of the systemic examination was within normal limit. So to summarize the case now, we have a 14-year-old, well-growing girl born to a non-consanguineous marriage, immunized for age, developmentally normal, with a subacute onset cough for the past 2 weeks, along with difficulty in breathing and chest pain for the past 1 week, with bilateral pleural effusion, without any history of fever, weight loss, contact with a case of tuberculosis, any history of ATP, recurrent severe past illnesses, any severe skin infections, with normal anthropometry, but tachycardia, respiratory distress, and mild hepatosplenomegaly. Prior to coming to us, the child was admitted in a health facility for 7 days. That was 7 days back. And in this health facility, this was the radiograph which was done, with which the child was referred to us. With this radiograph, the treating team in the previous health facility did a hemogram and a pleural tap was done. The hemogram suggested a TLC which was normal. The CRP was normal. So the inflammatory markers were normal. The pleural tap revealed 5,200 cells with predominantly lymphocytes. The sugar was 157 milligram per deciliter. Protein was 5.3 milligram per deciliter. And LDH was also raised. So in this health facility, they did a pleural tap. So bilaterally, they were able to remove around 1 liter of pale white fluid. The child was started on injectable IV antibiotics, but in view of inadequate response in terms of persisting distress, cough, and chest pain, the child was referred to us.
So may I ask you, Professor Kamal, a very important but a basic question of approaching this child. You have initial pleural effusion, pleural tap, and often we found that we get referrals where pleural effusions are treated without doing a tap. So what's the relevance of doing this tap, and how does one interpret these findings of pleural effusion with normal inflammatory markers in your case? What are your thoughts on that?
Yes, sir. So if you look at the overall clinical scenario, it is not just one test that will give you a definitive answer. It will be a combination of clinical history examination, radiological evaluation, and then culture, the other antigen or antibody tests, histopathology reports, cytology results, that will give you a final answer. But to begin with, in terms of investigation, differentiating whether this pleural fluid is transurate or exudate can help you think of differentials. Now, in this particular scenario, if you see, if the pleural fluid is exudative, which means the absolute protein is more than equal to 3 grams per deciliter, or the serum or the pleural fluid to serum ratio is more than 0.5, it is exudative. Or if the LDH is more than 0.6, this will indicate an exudative kind of an effusion. Now, if you look at the textbook table, What are the exudative or transitive effusion? In our scenario, the transitive effusion was unlikely. There was no cardiac, no vascular anomaly, renal, liver. All these diseases were not there on history itself. And now, if you look at exudative effusion, in terms of the epidemiology that we see here, the most important and likely cause is infections, and it will include empyema and things like tuberculosis. After that, what we see is probably malignancy, which can include some kind of a leukemia and lymphoma. Other than that, you can have connective tissue disorders, vasculitic disorders. So this is the bunch that we usually see in our encounter, in at least in this part of the world. Other than that, to complete the list, if you look, it could be a lymphatic anomaly, it could be abdominal pathology like pancreatitis, subphrenic abscess, or a post-operative complication, or pulmonary infarct. So if I have a child with this kind of a presentation, this is the list that I would look at and evaluate clinically. So this child, on arrival to us, has persisting distress, but he's still afebrile. There is bilateral pleural effusion, which is persisting. So one thing which the previous health facility probably overlooked or missed was there were multiple expensile lytic bony lesions, and they were there in multiple ribs. They were there in the ribs, in the scapula, and in the humerus. So if you can say, the pointers can indicate a lytic lesion in the humerus, a lytic lesion in the scapula, and the rib. I'm not sure how it is being projected there, but on a hard film, it was well seen. So this was an important clue that was missed at the previous health facility. And ultrasound suggested bilateral pleural effusion with no pericardial effusion. With this in mind, we looked at the investigations again, and in view of persisting distress, a radiology suggestive of massive pleural effusion, a repeat tap was done. And what we saw here again was that the inflammatory markers were not raised. So the systemic inflammatory markers were not raised, and the pleural fluid again suggested an exudative kind of an effusion with a cell count of 7,000, but still predominantly lymphocytic. The cytology did not reveal any malignant cells. So based on this, intercostal drainage tube was inserted.
Yeah.
Here is a child who has bilateral pleural effusion, lytic lesions in the bone, hepatomegaly, with no evidence of pericardial effusion. You heard what the house feels. But as an expert, how do you think we should be aligning our diagnosis? What is there in favor or against these diagnoses and how to proceed further? Over to you, Professor Gao, if you can educate us further. Thank you.
Yes, yes, thank you. And I think it's complicated cases. And thanks for Dr. Kamal gave us the important new clues, and that is bone lesions. I think let's continue to talk about it. And for bone lesions, I think there are two types, lytic and blastic. In lytic lesions, that means the destroy of the bone materials with loss of cancellous and cortical bones. So it can be seen in many diseases, but there are a series of reasons can explain the bone lesions. The most common is malignant disease, and such as the bone tumors, and also have some hematologic cancers. The second, infection, especially for TB and fungi disease, and others such as LCH, and also have the vascular malformation disease, especially the lymphatic malformations. And different disease may have different bone lesion features. It can be isolated or multiple. For our patients, and we can say it's a lytic bone lesions in multiple ribbed and humerus, capillaries, and so it's a type. So can move the slide. It's a type of the multiple lytic bone lesions. So for this, we should consider the following disease. The first one is lymphoma. So lymphoma can involve any part of the skeletal system. It can primary or secondary. A secondary is the most common, and such as in Hodgkin disease and non-Hodgkin disease. And the bone involvement in children is approximately 25%. The bones can including the spine, pelvis, and skull. And from the radiological findings, we can say it's a primitive bone destructions. And in the chest CT, we can say it's enhanced signals. But for these patients, even though she don't have the typical lymphoma symptoms such as fever or lymphadenopathy, but we should do bone marrow test and PET-CT and bone biopsy to make sure. The second disease is the LCH. LCH is another common disease. It's usually with multiple bone lesions, and the radiological findings is a punched out appearance like this. And in children, the most frequent sites are skull, nearly 40%, except the bone, and also can affect skins. So the patients maybe have the rash, and also to involve the liver, spleen, lungs, and in the chest CT, if involved in lungs, we can say the bilaterally diffused cyst with nodulars. So we should to check these patients whether have other bone involvement, and to check the lung involvement feature to do the chest CT. And finally, to do the definitive diagnosis is to do the bone biopsy, I think. Yeah. The third disease, is TB. And TB can involve the iron bones of the human body, as we can see from the picture. And skeletal TB account for 5% of all TB cases. And spine are the most frequently affected. So because if the TB in the radiology, and we can say is have destruction of the cortical bones, and also have the periosteal reaction, or have the enhancing tissue component in the CT, we can say. And it's a multifocal TB involvement, and it always mimics to tumors. Except for the bones, in these patients, bone pain may be the main symptom for these patients, and also have other symptoms for TB. So we should to check the TB pathogen, and also to do the biopsy to show whether the tissue have the typical calcitonin glomerulus status for these patients. So if these patients have the disseminated TB, and we also to keep in mind for a rare disease, inborn iron immunity deficiency disease, that previously we call it primary immune deficiency disease. So we should to check the patient's immune function also to make sure. So next, and other reasons also include metastasis or the vascular malformations, and especially for lymphatic malformations also can accompanied with the features of pleural effusion. And other uncommon disease such as sarcoidosis should be as a differential. So next. So about talking about this and consider the situation of the patients. And we now focus on this lymphoma, TB, and vascular malformation, especially for the lymphatic malformations. And the other uncommon disease should be as a differential diagnosis. So what to do the next? We should to do the related detections to make sure the definitive diagnosis we mentioned about. Yeah.
Thank you, Dr. Kaur. I think it's time to ask Dr. Kamal, what did the treating team feel when they saw this patient? How did they proceed? So we heard the expert as to what are the likely options, and let's see what the treating team thinks about these options and what did they do. Over to you, Dr. Kamal.
So, thank you, Dr. Leve. We also thought on the almost the same lines, and with the massive amount of effusion which was rapidly refilling with lytic bone lesions and hepatosplenomegaly, lymphoreticular malignancy was something that was right on top, but without any hematological abnormality, without any lymphadenopathy, without any fever. That was what was odd. For disseminated TB, I think one of the most common diagnoses that we would see in a child with exudative pleural effusion in a high burden setting, but along with mild hepatosplenomegaly. And lytic bone areas are also seen, but no fever, no weight loss, no decreased appetite, a well-growing child who has not had a contact with TB, without lymphadenopathy. And wherever these lytic lesions were there on radiology, the overlying skin and soft tissue was normal. That was something that was not fitting into a diagnosis of TB either. The third one, Langerhans cell histiocytosis. Of course, we have bony lytic lesions, but again, no other bony lesions, skin lesions, no other skin lesions. So that again was not something that was fitting into this. So still, we although we had our thought process going, but it was not fitting into this particular scenario. So for these possibilities that were considered, the child was investigated. The gastric aspirate was sent for cartridge-based nucleic acid amplification technique, which did not reveal any mycobacterium tuberculosis. The blood culture did not grow any organism. The coagulation profile was normal. LFTs, kidney function tests, thyroid function tests, the ANA were all normal. We looked at immunoglobulin profile, which was normal. Retrovirus was sent, which was also non-reactive. So we did a bone marrow aspiration bilaterally, along with bone marrow imprint, with these things in mind, Langerhans cell histiocytosis and all these things. But there were no malignant cells. The staining for LCH was also negative. So it was essentially a normal bone marrow. We did biopsy from these lytic bone lesions, which was one of them was there in the femoral right trochanter. Again, it revealed only normal bony tissue along with some blood, nothing abnormal here. We looked at the parents' radiological survey, which you do both for TB as well as for these lytic lesions, that was normal. Additionally, we did an echo, which was normal. So we went ahead and we did a CT scan in this child. This is the lung window that we see in this of this child, and it showed bilateral pleural effusion with segmental collapses, and the segmental collapse of the posterior segment of the right lower lobe. But there were no other significant lung parenchymal or mediastinal pathology seen here. So we do not have a lung parenchyma or mediastinal pathology other than a pleural effusion compressing the lung. These are the mediastinal windows and the bone. What we see here is multiple lytic lesions. What we have shown here is even in the skull, there was a lytic lesion which is marked. On the right hand side, we have a cut section which shows the spleen, which showed multiple hypodense lesions. On the left side, we saw a hypoenhancing left supraclavicular lesion, which was interpreted by a radiologist as lymph node at that time. So we have multiple lytic lesions, some lesions in spleen, and then a left supraclavicular lymph node. Now, with this in mind, our clinical, we looked at our clinical possibilities again. Again, for lymphoreticular malignancy, a chest radiology not showing any lymphadenopathy, both bone marrow aspiration as well as bone biopsy from the lytic lesions were normal. For TB, it is very odd that with these lytic lesions, you will not have any soft tissue or any swelling or any periosteal reaction. And the molecular test for TB was also negative. As for LCH, again, the lung parenchyma to be spared is odd. And the presence of such significant pleural effusion is also very odd. So, and the bone marrow aspiration and bone marrow biopsy also was not supporting the diagnosis. So, with these things in mind, over the next 7 to 9 days, what we saw that the child was although stable but continued to have respiratory distress. Over next 7 to 9 days, the pleural fluid, which was initially blood stained, now started appearing milky. And the biochemical investigation confirmed it to be chyle. So we had a which had a cholesterol which was 178 milligram per deciliter, a triglyceride which was 234 milligrams per deciliter.
Wow. So that's another twist. You're bringing up some twist or the other. You started with pleural effusion, then you pointed out some lytic areas, and now it turns out to be that we have some milky pathway coming our way, the milky pleural fluid. Are you going to be lost in this milky pathway in the sky, or we're going to find our way out of it? So let me ask our other expert, Professor Bulan Karado. Karada, what do you think this possibly could be when you have a child who has bilateral pleural effusion, which is milky now, has osteolytic lesions and hepatomegaly, and a variety of investigations done, including bone marrow biopsy and aspiration, which are showing no pathology. What are your thoughts on this? Over to you, Professor Karada.
Thank you very much, Professor Varinder. It's really a challenging case, and really like I feel myself traveling around the Milky Way. First, no, pleural effusion was not milky and not representing any features of chylothorax, but now we are in the middle of the diagnosis of chylothorax, and as Dr. Kemal stated, first of all, we should be sure that it's really a chylothorax. So we should first define the cholesterol level, which is high, and then look at the triglyceride levels. Again, it's high. So in that stage, if there is no contamination of triglyceride, we can be confident about diagnosis of chylothorax. So I think first we should be sure about the diagnosis of chylothorax, but in that case, I think we are sure. Next slide, please. And then another point is whether it is a chylothorax or pseudochylothorax, because also it should be in our minds. Chylothorax is characterized by the presence of chylomicrons, in addition to the definition of chylothorax. But in pseudochylothorax, we don't have chylomicrons, and we have neutrophil predominant exudate. So the only thing, for example, for this patient, of course, she is in the second decade, but we need effusion more than 5 years. And as the cholesterol level is high and triglyceride raised, I think in that case, we are talking about chylothorax. Next slide. And also, when you look at the differential diagnosis from the beginning, tuberculosis is always our mind. As physicians in all these regions, all these countries, we are all familiar with tuberculosis, and we should keep tuberculosis always in our minds, in every patient, because we know tuberculosis has 1,000 faces. So nothing is impossible for tuberculosis. Of course, tuberculosis is, again, it should be in our mind, but of course, congenital lymphatic malformations, and especially one of the participants also wrote a message about Gorham-Stahl syndrome. It can be another differential diagnosis underlying this situation. Next, please. And when we look at the differences between the generalized lymphatic anomaly and Gorhamstadt disease, of course, bony lesions not involving the cortex is important for GLA, and it is non-progressive, and fractures are unlikely. But in Gorhamstadt disease, we expect to see fractures and have progressive course of the disease, and also infiltrative soft tissue lesions is another important aspect. So also the approach to these two entities are somewhat different. Of course, there are some overlapping patients that really difficult to diagnose. Next, please. And also with regard to the tuberculosis chylothorax, although it is rare, it is recognized. We have published data. There is a good review, meta-analysis of the cases, and showing presenting 10 cases. One of these cases was our patient. She was 4 months old and had TB and tuberculosis. So pleural effusion is something around 1 in 3, but it's rare for chylothorax. In our case, you can see here, again, we didn't look at the chylothorax, chylomicrons, so maybe someone can be in that, but as she's only 4 months old, I think it's mostly due to the chylothorax and tuberculosis. Next slide, please. And so likely possibilities again, we are again thinking about GLA, infection again, Gorhamstadt syndrome, and although we couldn't identify any symptom or any present any characteristics of malignancy, of course, it should be in our mind. Yes.
Okay, thank you so much, Professor Karaja. So let us go back to audience. We have been getting some options from in the chat box. Let's see, what do you think now? A child who has bilateral pleural effusion, which is exudative, with lytic areas, with no organomegaly, no lymphadenopathy, bone marrow aspiration being normal, and a bilateral chylothorax now. It's not pseudochylothorax, it's rapidly filling, something which is less likely with TB, but okay. What do you think? What would be your first diagnosis in this case? We do realize the fact that though the CBNAT was negative, but a negative expert is not an evidence of there not being any TB. We know this is a very good molecular test for TB, are very good for ruling in tuberculosis, but they are not good for ruling out because they have limited sensitivity. So this could still be tuberculosis. Could it be a malignancy? Could it be a generalized lymphatic anomaly? Or is it that we still are not sure? What does the audience feel? So out of the 205 odd participants I can see now, 70, I see 70 people have polled. So maybe we can stop now. And the generalized lymphatic anomaly gets the maximum options, which is about 50%. Earlier it was LCH, and now it has LCH has been out, and disseminated TB still remains with about 30%. About 15% feel that it could be some other malignancy, and 11% feel they aren't sure even now what it is. Thank you. We can stop sharing these results, and let's now go back to the treating team and ask them, okay, with this situation, how did you confirm the diagnosis of these 3 or 4 options which are left with? What did you feel was the most relevant one, and how did you investigate? Over to you, Dr. Kamal.
Thank you, sir. So what we are sure of now is that with the biochemical investigations, we are sure it is a chylothorax. So the question now is why and how it has developed. So one thing to look at is it some trauma which has resulted in this, which was obviously not there in this child? So the next question that comes up is, where is that leak? Where is that obstruction which is resulting in this chylothorax? So there are various modalities that you have where you can localize the site. It could be a lymphangiography, lymphoscintigraphy, the MRT2 weighted non-contrast lymphangiography, and dynamic contrast MR. So depending on whatever is available, whatever is feasible, you can choose depending on your scenario. So we had MR available with us, and it again presented in much greater detail the lesions. So on the left-sided image, you can see it's a T1 red image where you can see a lytic lesion in the in multiple vertebral bodies. And then the two right-sided images are the STIR hyperintense images, which showed non-expensile cystic bone lesions. So now the radiologist on this MR felt that this is generalized lymphatic anomaly. Rather now, with this picture in mind, based on that CT, they are sure that this is lymphatic anomaly only. But that is as a hindsight. So we again went ahead with a lymphoscintigraphy, but it did not reveal to us a site of obstruction or the site of leakage in this particular child.
Okay, so if it is a chylous effusion, there are several treatment modalities, and whether it will be different for GLA is another question which comes to our mind. So the usual things, which is dietary modification, or we have to go beyond, these are the questions which must have troubled the treating team. I wonder what our experts have to say on this. May I request Anna Nathan to guide us and the audience as to what are the possible treatment modalities for bilateral rapidly filling chylous effusions and how do we manage them? Over to you, Anna.
Okay, thanks, Verinda. So we're at the last lap of this very interesting case. And while I've been tasked to talk about the management of chylothorax in GLA, let's first look at this table, because to treat this patient, you must know exactly what the etiology, because as you can see from this table, there are multiple types of lymphatic malformations. And each different type may require a different type of treatment, or the treatment may need to be tailored towards the type of malformation seen. So as for next. So here in this very nice Venn diagram, you see 4 types of lymphatic malformations which are of major interest to pediatric pulmonologists, because these are the types that usually cause significant chylothorax, the type of chylothorax that you see in this patient, where the fluid is pouring and pouring, and you wonder when is it ever going to stop. So looking at this Venn diagram, you can see that under generalized lymphatic anomaly, you have this Kaposiform lymphangiomatosis, which is a subset of a GLA. For those who may not know what Kaposiform of KLA is, it's a very severe form of GLA, and the mortality can be as high as 50% or above. But there are a chat group called Stout disease and CCLA. And these all do overlap. So their symptoms and their signs do overlap with GLAs, and but their treatment and their management may be different. Okay, next slide. So let's go to how we can treat this patient. So first and most importantly is that we must talk about the fluid drainage. And again, as pediatric pulmonologists, sometimes we are very enthusiastic and we really want to get at this fluid. But perhaps some of these patients may not require a chest tube, but just a pleural tap to determine, first of all, the etiology, especially if the fluid is not causing any respiratory compromise. But once a chest tube is required for respiratory compromise, controlled drainage and meticulous replacement of these huge fluid losses cannot be underestimated, and it's extremely important. Next. We must also be very wary of all the multiple complications that can occur because of all the massive losses of this lymphocyte protein-rich fluid. And sometimes even intravenous immunoglobulin G may be required because these patients' levels may drop and increase their risk of sepsis. Nutritional care is also obviously very important. The patient should be put on a low, long-chain fatty acid diet, and this should be replaced by medium-chain fatty acid. However, a diet that is high in calories and supplemented with vitamins and minerals is also essential. However, if this does not work, TPN, although being highly aggressive and keeping the patient nil by mouth, may be necessary. Many of us know octreotide, which reduces the lymphatic absorption from the gut. But this may not necessarily be useful in GLA, for example, in the current patient, where you can't actually find the leak or where the obstruction or the problem is. And so and octreotide may be useful more in CCLAs or traumatic causes of chylothorax. Finally, once you have determined the cause, directed treatment should be instituted. So for example, in GLA, chemical pleural disease can actually be successful, and some experts even suggest repeating the pleural disease up to 3 times to achieve success. While there are many agents which can be used, iodine is the most commonly one that is reported on and has got good efficacy with reduced side effects. However, for chemical pleural disease to work, the residual chylothorax has to be small. And so if one cannot seem to reduce the size of the effusion, then surgical pleural disease may be better. As for medications, there are many reviews on the efficacy of sirolimus in both GSD and GLA. Sirolimus is an inhibitor of the mTOR pathway, which has been implicated as a cause for GLA and GSD. And sirolimus has been shown to stabilize and improve patients in up to 80 to 100% of patients with GSD and GLA. If you have a patient and you suspect the patient has GSD, then bisphosphonates should also be used to reduce the osteoclastic activity implicated in this disease. Now, as for the rest of the medication with the question mark that I have in the box, there are many case reports supporting their use, but usually it is these drugs with other modalities that should be used together. Finally, surgery is usually kept as a last resort, but may depend on your available expertise in your setting and may be useful not only for diagnostic purpose, but may also be therapeutic. For example, again, assisting in surgical pleural disease for GLAs with very large effusions. This next diagram shows the different pathways. Next. So this next slide basically shows the different ways at which using the chest tube output can help guide our treatment modality. So for example, once the chest tube is less than 10 mils per kilo per day, it is most likely that your patient is responding to the current treatment, and you should probably just plod along patiently rather than trying to initiate a new drug or do anything new. Next. And finally, this is my last slide. This just shows where both sirolimus works at mTOR, whereas if you have a patient with CCLA, you can use MEK inhibitors, for example, like trametinib, which works at the RAS-MAPK pathway.
Okay.
That's it for me.
So we realize that just using first thing which comes to our mind with chylothorax is usually an octreotide. Possibly this is not what will work when you have your GLA. And what you need is something which will primarily affect either through an mTOR pathway or a VEGF pathway to decrease it or both of them. And more important, which what I heard from our expert is that we need to take care of the nutrition. It's the nutritional complications which will make the outcome more worse. And there is a need for surgical uh, intervention if we are not able to stop the refilling of chylothorax by any degree of attempts at pleurodesis. And particularly when they are rapidly filling, it will not be an easy thing to achieve. And I do not know what troubles Dr. Kamal went through when he was managing this case. Let's hear from him. What did they do under these circumstances? Over to you, Dr. Kamal.
Thank you, Professor Anna. Whatever you have detailed and whatever you have enumerated, the child was with us for quite some time. And almost all of these complications we had to fail. Now, because the schedule was so tightly packed, we could not pick up everything and put it here. But almost everything. She was losing so much of fluid that she rather went into a prerenal AKI. She had hypoalbuminemia. We had to give IVIG. So many of the things that you said, we had to. So we had a tough time. So initially, we of course began with something like octreotide and propranolol. But over the time, we realized they were not working. And the child continued to have significant pouring of pleural fluid from bilateral tubes. And so sirolimus was started. and the choice was more of what was available to us at that particular time. And for these ultra rare diseases, what you have in terms of evidences is case reports and case series. So this was available to us, and we went ahead and we gave it a try. So with sirolimus, as we know, it would take time. Again, we had significant effusions, so we tried pleurodesis, bilateral, with povidone multiple times, and then, despite all this, that octreotide, propranolol, all supportive care in terms of dietary management and all, the child continued to have severe respiratory distress. And at this point of time, when we had this radiograph, the chest X-ray showed mediastinal widening and capping, and the child was in severe respiratory distress, almost like impending respiratory failure. So we thought whether it is a progressive primary lymphatic disease which is going on, or is it some kind of a loculation that we are not able to drain. But because we had intercostal drainage tubes bilaterally and they were moving well with the respiration, we know it is in the right place, but still the child was having severe distress. At this point of time, we went ahead and did a contrast enhanced CT. And what we saw in the CT was that there was a large lobulated multi-compartment cystic mass in the mediastinum with extensions and encasement of great vessels. So the radiologist here felt that it is the primary disease which is going up and not getting controlled. But what they also pointed was that there is a subpulmonary collection on the left side, which was quite significant. And at this time, I would tell you, after the CT, we had to transiently ventilate the child, and we were able to get him off. And we put a guided tube into this. And in that phase, vincristine was also initiated in addition to sirolimus, and we did a pictal guided drain. And here we did pleurodesis with blomycin. And thankfully, as God was probably with us and the child had a marked relief with this particular tap which was done. So pleural fluid was drained, but then a new thing jumps up here. The pleural fluid, which was sent initially, now on liquid culture, which comes after say 6 weeks, grew Mycobacterium tuberculosis. And we were still fumbling with the diagnosis, but given this scenario on a culture we could not ignore, the child was additionally started on anti-tubercular therapy. And gradually the bilateral pictal output decreased. And finally, it was removed on 25th of October. So almost 3 months, 2-3 months, the child was with us. And thereafter, the respiratory distress gradually reduced, and the child could be shifted to oral feeds. So this is the graph which summarizes what happened in terms of pleural drainage that we were seeing. So the blue lines here, they show the right-sided ICD drainage, and the orange one show the left-sided intercostal drainage tube output. And as we see, when the sirolimus was started, it was still going up and up, almost like 1.5 to 2 liters per day. And this phase was very difficult for us to manage. And then when the pictal drainage was done, suddenly it started coming down. And it was on 9th of October that finally anti-tubercular therapy was started. So what this graph suggests, how to interpret that graph, is probably open for each one of us. So
yeah. So here comes another twist to the story, and now you have a culture positive MTB. I do not know what does the group feel about this. So would the audience like to comment? Do they think it is a GLA or a pleural tuberculosis with the chylothorax, or a GLA with pleural tuberculosis, or they are yet not clear as to what it possibly could be? So let's see how the audience responds to this. Mind you, the lymphatic drainage started decreasing before ATT was started, though ATT, when we started ATT, we were able to get to an endpoint of removing the tube. Drainage had not stopped, it had decreased. Okay, so, but decreased significantly. child never had any constitutional symptoms, and this is what it was. So, what do you think was going wrong with this child within this? Okay, we have an overwhelming 71% of the people who have polled saying that it is a combined disease, GLA and pleural tuberculosis. That's interesting to know, and I wonder if Dr. Kamal will also give us the follow-up of this patient as to was that the end of the story or something more happened as we went by. Kamal?
So we are expecting more twists. So I don't have many now. So we considered both as a possibility. We cannot rule out that it cannot be a generalized lymphatic anomaly given the overall clinical scenario, the whole clinical course. So it had to be a generalized lymphatic anomaly, which we thought of with bilateral pleural effusion, with bony lytic lesions, with splenic lesions. But then it is probably associated with pleural tuberculosis. Um, we started the child on antitubercular therapy, but additionally, sirolimus was continued. It was not stopped. So the radiograph that I'm presenting here on the left one is at the 9 weeks of sirolimus and 2 weeks of antitubercular therapy. And the one that I previously shown was when the child was very, very bad. So by this time, the child was so well, she was off oxygen, feeding well, and we were able to discharge this child at this point of time on sirolimus and antitubercular therapy. And the next X-ray on the right side is at 20 weeks of sirolimus and 13 weeks of antitubercular therapy. The child has markedly improved. There is a weight gain from at the discharge weight of 34 kgs. She is now 41 kgs and she has no respiratory symptom, and there is a good radiological response also. Just to give you a pictorial representation of what we had in this child, the left image is when we just before we inserted that subpulmonary drain, when the child was after this intubated also for some short period of time, and the right picture is the glowing child at the time of discharge. So the God was with us and the child, and this is how it all fared.
Thank you.
Over to Professor Vandya Singh.
I wonder the enigma is now solved or it's still unresolved. Because if one looks at it, what are the key learnings? What do I take home? The patient had to begin with an exudative effusion, which did not look like others. As a routine, being in a high burden country, a culture was also sent. It was perhaps low bacillary count because that is why there were, as it is, pleural effusions are low count. So the molecular test was negative. And even the culture took longer than 2 weeks to become positive. So it came around fourth, fifth week that a positive result came our way. And that was also not something which we were expecting. It was sent, but it was not something active in our mind because absolutely no fever, nothing else, no other suggestion of TB, no parenchymal lesion, no lymphadenopathy on CT had practically made TB as a diagnosis which was nowhere there. Because if you look at lytic areas in the skull or in the appendicular structure, yes, lytic lesions are seen with tuberculosis, but they're never silent. They would have some degree of skin involvement, cold abscesses, some discoloration above it, because they are not simply osteolytic. They are representing osteomyelitis. So that's something which we did not see in this child. So just because there were all the areas in the bone were punched out like that, it was not an occasional punched out area and other areas showing different other forms of bone TB, that made it much less likely. So once the child started having some clearance of the infection and it started pouring chyle, we started thinking more in terms of a GLA, though it was there at the back of the mind with some of the findings of on the CT showing some non-homogeneous shadows in the subclavicular area, a mass which was query lymph node, query something else. However, none of these routine investigations confirm the diagnosis of a lymphoid anomaly. That's one point. And it's a very rare disease. So one therefore tends to always rule out the common diseases first and then get to the rarer diseases. Could we have done a genetic test? But this is something which happens with the somatic mutation, and it was not that easy to identify in this child, and cost was an issue. We did not. If it was not, it was a germ cell mutation, then some ethical reason to push for it for a future, counseling of the family was there. But it being a somatic mutation and the facility not being available and it was expensive, that was not something we could have done to confirm it. So the second best way to confirm it was through MR, lymphangio, stir images, which finally clinched the diagnosis. And what pushed us there was the chylothorax. If I look for a binding way where one could have looked at both of these together, possibly this child had a pleural effusion because of TB, and because there was an underlying GLA, the lymph nodes which got enlarged, or the lymphatics, that anomalies tend to leak more than the usual. It's an hypothesis. I do not have any support from literature on this because there is very little literature on this. That's all I can hypothesize. Possibly was the reason for having a test which is culture. You cannot ignore a culture positive. If it was a molecular test, one could have argued and said maybe it was a prior infection and we were looking at a dead bacilli. But when you grow culture, MTB in culture, you don't doubt it. And though we are trying to retrofit it, but that's what it is. And the response to ATT suggests possibly we were dealing with a combined diagnosis. So I would say a very enigmatic case, and possibly a lot of questions, debates on the way, which the treating team, and I would like to acknowledge the treating team with Dr. Kamal, Professor Pyali Mandal, and Professor Pooja Ebe, who helped us a lot in managing this case. And that is where we were finally able to help this child. And what is quite encouraging for all of us is that our experts, when we unfolded this case today, we had to, for the purpose of education, it looked like every slide was made. But when independently these cases were sent to these experts, they had a similar view, and it was good to see that the treating team did a good job on aligning with what most other experts thought about it. So I congratulate Dr. Kamal and Dr. Pyali Mandal and Dr. Pooja Ebe for this excellent management of the case and diagnosis of this case. And thank you very much. I hope I learned a lot from this case. I hope you did too. Over to you, Dr. Arunwan. That's all from our end. Thank you.
I have seen some comment about T cell function. There's some question about, are you planning to check her for T cell immunodeficiency?
The child is absolutely healthy. We will send the flow cytometries, but she has absolutely no clue, none whatsoever, to suggest an immune deficiency. So that would be a wild goose chase. We should attempt investigation if there are any pointers for it.
Okay, and there is another question. Did immunosuppression due to sirolimus accelerate the chylothorax?
That's hard to say. We did find an initial increase. What I think helped was not only sirolimus. If one goes back to the chart which Professor Kamal showed, what helped was a good drainage. Our initial attempts to loculate or decrease it by pleural addition had led to several loculations, and the large loculations were not being drained. Till CT helped us to know, no, when we were doing chest X-rays or ultrasounds and there was a constant drainage, you felt I am draining fluid, and this column is moving, so this everything is good. When we did CT, it did tell us no, this you were emptying out some of the large pockets, but not all. So when we went to the pockets which were not being drained and put pigtails there, that allowed the additions and then allowed the sirolimus to work. Sirolimus alone was neither the reason for response or a reason for increase in flow. I think it was a combination which was required, and drainage played a very important role in there. And that is why pleural addition, pleurodiasis comes very up in the management, as Anna had shown to us in these situations. Unfortunately, it was filling up so fast that it was not so effective.
So I would like to congratulate all the team who take care of her. I think she received an excellent care so that she can return to her usual life in a good with a good quality of life. I would like to express my sincere gratitude to all speakers who volunteer to give your time and effort to doing an excellent work to all of us. And I think we can create a good relationship between Asian experts in pediatric pulmonology in the future very well. And I would like to announce that our next grand round will be hosted by Singaporean friends, who is Dr. Mahesh and Dr. Anko. So I would like to welcome you all again to join us for the next grand round hosting by Singaporean pediatric pulmonologist. Thank you so much.